This meeting is being recorded for the minute-taking purposes, as well as posting the recording of the proceedings on the agency website. This meeting is also being live streamed on the Access Health CT website. I'd like to call this meeting to order, the Health Plans, Benefit and Qualifications Advisory Committee special meeting for January. I remind everybody to please announce who they are before they speak, so we can hear your voice and kind of recognize, put it with a name. This is Grant Ritter, Chair of the committee.
Okay.
First thing.
I'm sorry, go ahead, sir.
Yeah, first thing, I'd like to take attendance, roll call.
Okay, a roll call for attendance. Dr. Grant Ritter.
Here.
Sean King.
Here.
Mark Schaefer. Matthew Brackman. Dr. Manisha Jutani, DPH Commissioner. Tun Nguyen.
I'm on.
Thank you.
Hi.
Brendan Riff. Ellen Skinner. And Paul Lombardo.
Here.
Thank you.
Okay,
I think
thanks,
somebody
everyone.
just joined us. Somebody just joined us with the phone number. If you can just announce yourself. Okay.
Who
Thank
just
you.
joined by phone?
I think we can move forward, Dr. Ritter.
Okay, all right. Could I now turn it over to Susan Richby to tell us the purpose of the committee and sort of give an overview of it?
Thank you, Grant, and welcome everybody to our new season, if you will, for this committee for Plan Year 2025. The Health Plan Benefits and Qualifications Advisory Committee was formed following our enabling legislation and also the ACA. The exchange has been required from the beginning to get feedback from the community and from experts. So we decided to take the route of forming certain advisory committees. And then pursuant to that, the board in 2012, I believe it was, adopted its operating policy for establishing requirements for the certification, recertification, and decertification of qualified health plans. This is one of the exchange's responsibilities under the ACA. So the board created an operating policy for this work. And as part of that operating policy, it requires that the Access Health staff consult with the Health Plan Benefits and Qualifications Advisory Committee for developing these requirements. And we're charged with evaluating options and recommendations to make to the board about these requirements, and also looking at the different details for the plans. And for us, very specifically, that involves standard plans. Back in 2012, I believe it was, or 2013, the board decided that we would use standard plan designs that we would require carriers to offer, in addition to allowing for non-standard plans. So over these last several years, the work of the committee has really focused primarily on those standard plan designs and any changes we need to make or perhaps want to make for the following plan year. So that is the purpose of the committee. So I thank everybody for being a part of the committee and helping us with this work. And I will turn it back over to Grant and to Kelly for the rest of the meeting. Thank you.
We will move on to the next agenda item, which is I really like somebody that was at the February 27th meeting last year to give a motion to accept the minutes from it.
Dr. Ritter, before we do that, I just, for this particular agenda item, we did not receive any public comments for today's meeting.
Right.
Mm-hmm. And we'll move over to the vote.
I need a motion to accept the minutes. Hopefully somebody will chime in who was there. Could be a...
So moved.
Oh, thank you. Who was that, please?
Oh, sorry, Matt Brockman, sorry.
Matt, okay, great. Second?
This is two, second.
Oh, thank you. All right. Were there any comments, edits, changes to the minutes one would like to make? Well, hearing none, let's have a roll call vote to accept the minutes.
John Ritter,
Yes.
Sean King. Mr. King,
Sorry, I'll abstain.
Mark Schaefer, Matthew Brackman,
Yes.
John Goen,
Aye.
Brendan Riff, Alan Skinner, and Manisa Tutani. Thank you.
Okay, motion carries. Now, I'll turn it over to Kelly to discuss our mission and vision for the Access Health Connecticut.
Good morning, and thank you, Grant. Each year during the first HBBQ meeting, we share with the committee members the Access Health mission and vision statements, as well as our values, before we engage in the certification and standard plan discussion. So let me take a moment to review this slide with you. Our mission is to decrease the number of uninsured residents, improve the quality of healthcare, and to reduce health disparities through an innovative, competitive marketplace that empowers consumers to choose the healthcare coverage that gives them the best value. Our vision is to provide Connecticut residents with access to the most equitable, simple, and affordable health insurance products to foster healthier communities. Also included on this slide is Access Health's 6 core values. This is a guide that we all work by every day throughout the year. I'm not going to go over all of them. You could see the 6 that are on the screen. So with that said, let's move over to the plan management life cycle. I think many of you probably have seen this before. The plan management certification life cycle for plan year 2025 started in November of last year with the release of the information from CMS, and will end with the commencement of open enrollment November 1st, 2024. While I won't go into each task that's on the cycle, I wanted to point out the tasks in yellow are impacted by the work that this committee does. And while every task listed is important to our overall success, the items highlighted in red are the 4 major milestones that must happen as scheduled to ensure a successful and a timely open enrollment. So let me go over those just briefly. Milestone 1 is to make public the medical and dental solicitations and standard plan information to issuers for participation on the exchange. It's important for us to release this information in early March so that existing issuers have the opportunity to review the information, identify any impactful changes, and be able to have enough lead time in order to implement those changes. This information is also used by non-participating issuers to understand the standard plans and certification requirements should they have an interest in participating on the exchange. To meet this first milestone, the board of directors must approve the recommendations made by this committee. Milestone 2, the release of the medical and dental application, which goes to our issuers that have responded to the solicitation for the upcoming year. The application includes detailed requirements and supporting materials used by the issuers to submit their applications to Access Health for plan certification. This document must be released to all the respondents to the solicitation by early April. Milestone 3 is the receipt of the application from each issuer looking to participate on the exchange, and the beginning of plan management's review process for plan certification. I'd like to note that Access Health's certification submission date is the same as the Connecticut Insurance Department rate and form filing date, which happens to be June 1st. Between milestones 3 and 4, there's much collaboration happening across, between Access Health and the carriers. During this time, we're all busy reviewing information, asking questions, confirming data displays are as expected, testing that data, and making sure that that information is ready to present to our consumers of Connecticut. We work together as one team, and I'd like to take this opportunity to say thank you to our partners at Anthem, CBI, and CICI for their partnership during this process, during the certification process, and throughout the year. Milestone 4 is when the certification sign-off occurs for all the participating issuers and the release of issuer information to our downstream systems, such as HICS, for consumer window shopping, which is utilized by our broker community and some of our consumers. And then for open enrollment, which is November 1st. Milestone 4 can only happen when all the certification requirements have been met by each carrier and system sign-off has been completed by Access Health and each participating issuer. To ensure that each milestone is met, the following slide will outline the committee's timeline for plan year 2025. So this exhibit's been, or this slide has been modified a little bit. And so I'll just walk you through it pretty quickly. As mentioned on the previous slide, the submission date for plan certification is June 1st, which is highlighted in the orange oval. It's likely that this group again will provide recommendations to the board of directors prior to CMS finalizing the notice of benefit and payment parameters or the actuarial value calculator, as well as the IRS communicating the HSA limits for the upcoming plan year. Should those finalizations, the finalization of this information have a material impact to the certification requirements or the standard plan designs that we have discussed, we may need to reconvene. But looking at this timeline, in order for us to hit the milestone 1, obviously we've been in receipt of all the draft information from CMS, so hence the start of these meetings. We do have 2 scheduled meetings after this, which are dated February 5th and I believe February 20th. And during that time, we'll discuss the plans and hopefully we'll be able to come up with a plan to present to the board of directors in early March. So based on how those conversations go, we will then give a specific date for each one of these targets. But right now it's a little too early to set dates. So in order to hit milestone 2, which is releasing the application and supporting materials to the issuers. As we've done in the past, we have released it prior to getting final information from CMS. Last year, we released the application to the issuers on April, I believe it was April 6th or April 9th. I think it was April 6th. And CMS release the final information on April 17th. So again, to my comment before, if anything material happens, we may need to reconvene. So the goal is to be able to get all that information to our issuers so they have plenty enough time to be able to respond back to Access Health on June 1st of 2024. If there aren't any questions regarding the timeline or key milestones, we can move on to the next slide. Certification requirements. So this is a familiar slide. To the left of the screen, these are some requirements that we have discussed over the years, not necessarily in the prior year, but I think over the past multiple years. And this is just to kind of keep a tick point. So if there's certain things that we would like to rediscuss going forward, we can mention them here. For 2024, the only items that we actually modified is represented with a check mark, and that was related to the standardized plan development for the medical plans. So for 2025, our suggested topics are to discuss the standardized plan development for the medical plans as well as the standalone dental plans.
Mhm.
Next slide, please. Thank you. So we wanted to put some information out here with regards to health equity strategy. Health equity has been a really hot topic. Plan management has participated in meetings coordinated by CMS, the American Academy of Actuaries. We have read materials from various sources. We've reached out to other states or read other states' ideas and thoughts or implementations for the upcoming year. But bottom line, after listening to everybody speak, there's really no quick fix for health equity imbalances. This is going to be a multi-step process to develop over the next several years. But however, in every conversation, we've heard a constant, and one of that is that people find health insurance confusing. They don't understand it, and it intimidates them. It's scary, and so what we've thought is one of the things that we think we could help address now is looking at health insurance literacy. So last year, our marketing team, led by Carolyn Bruette, organized several consumer surveys and shared the results with us. While each survey had separate purposes, that message from our consumers of not finding insurance confusing came out loud and clear. We've listened to CMS, and CMS is finding the same thing on the federal platform. So what are we going to do about that? Plan management, we've talked about it. And one of our focuses this year will be specifically on literacy. We've engaged our technical ops analytics team led by Rebecca McClear to look at our consumer enrollment tool and make enhancements based on direct consumer feedback. We're looking to refresh the benefit information and comparison tools that are utilized within the consumer enrollment tool to provide the consumer a larger picture of the benefits, but also in a very clear and concise way, trying not to confuse them and give them some really helpful information so that they can understand how their plan actually works. We're also looking to update messaging that's within these tools to make the user experience that much better. So we're in collaboration with our marketing team led by Caroline. And also with our outreach team led by Tammy Hendricks to update some of our consumer materials as well. We're looking to eliminate that insurance jargon and provide information that's in an easy to read format, and will help educate the consumer on topics such as, but not limited to, how to select a plan, how to define how a plan works for the consumer. Does the deductible apply? Doesn't. Well, what does that really mean to me? Really getting down and really helping some people understand the ins and outs of the plan so they may use it to their benefit and become healthier. There's way more to come on this. We're only in the infancy stage, but definitely throughout the year, this is going to progress. So for next steps, we've identified some on this slide, but honestly, as we go through our conversations in this meeting, have more conversations internally, I truly believe that list is going to evolve. So that's not, just what we're going to focus in on. Any questions on that slide before I move on? Excellent. So this next slide is a refresher for the group, which outlines the standard plan requirements and maximum plan offerings for the non-standard plans by market. One thing that I'd like to note on here is that no carrier offers the maximum amount of optional plans in either market. Next slide. This next slide outlines for our on and off exchange carriers what types of metal levels they're offering and the type of plan. On exchange plans have been highlighted for your ease, but for plan year 2024, we have 22 medical plans offered in the individual market and 5 for small group. And we have in the individual market, we do have a nice selection of plans, whether it be an HMO, POS, or PPO plan. Next slide, please. This plan mix is for our standalone dental plans. There's no difference between individual and small market as far as permitted number of plans. So therefore, they're all on one screen. And it's also identifying how many plans we have on the individual market versus small group. And I think everybody is aware that we have 6 plans on the individual and no dental plans offered to small group. Next slide, please. So before I go over the proposed 2025 standard standalone dental plans information, James had asked that I share with you that for the second year in a row, our dental enrollments through Access Health have increased. While Rebecca McClear, our director of TOA, will present the final enrollment numbers to this committee in February, it's estimated that over 5,000 new enrollments have been received to date. This is quite an achievement, and we're very excited to see this product continue to grow as it has. So just wanted to share that good news with you guys. So each year, CMS reviews and develops the incremental increases or decreases for the out-of-pocket maximum, which applies to the child benefits. And each year, this group analyzes to see if we would like to make any changes to the standard dental plan design. So to recap what we did in plan year 2024, the amounts CMS had communicated that the out-of-pocket maximum for the child coverage could increase up to $400 for one child and $800 for 2 children. At that time, the HBBQ recommended amounts remain at the $350 and $700 amounts. And just as information, amounts were last modified in plan year 2016. So for plan year 2025, again, CMS has completed their analysis, and they have identified that these amounts may increase up to $425 for one covered child and $850 for 2 or more covered children. Again, this is it only impacts the child benefit, and it only impacts in-network benefits. So as we did in the prior year, we've reached out to both carriers, or all 3 carriers, asking, actually both carriers, there's only 2 that are offering dental, my apologies, to indicate what the rate impact would be to the overall premium on a per member per month or PMPM basis. And the rate impact would not be more than 75 cents, which is not very impactful when you look at the overall rates, but wanted to present that information to this group so that as we think through plan design and the standard plan design for 2025, does it make sense to make a change to the out-of-pocket maximum? The next slide highlights what the standardized plan design is. And this is the proposed plan design with no plan design changes. It's following the same plan design that has been in place since 2016. So at this point, I will pause and ask if there are any questions from the group.
Yes, Kelly, hi, this is Grant. I don't quite understand what does the 75 cents represent? Is that if we kept the 350, 700, or is that inevitable? And that's what it's going to go, even if we raise it to 425 and 850? What does the
So-
75 cents really represent a difference of?
So the 75 cent PMPM is the rate change. Should we decide to increase the MOOP from 350 to either 400 or 450, or the two or more children from 700 to either 750 or 800?
Is that the savings we would recognize? I don't
Yes,
quite understand.
Yes, it's the reduction in the overall premium rate
Okay,
that the consumer would
it's a drop of
pay.
75 cents if we were to move
Yes.
it up. Okay.
Yes.
Gotcha.
But there's
So-
there's
Okay.
no requirement that we do that. And
No.
for the last several years, when we've looked at this, I think the committee has felt to leave it, as low as possible where we have it at the 350 and the 700.
Thank
Yeah,
you.
right.
Yes,
Yeah,
that makes
upping-
sense now. Okay.
Yeah, upping the out-of-pocket maximum, the $50 or $100 to save 75 cents. It's not really monumental, so. Thank you for that question, Grant. Sorry, I did not articulate that clearly. Are there any other questions? Okay, good. Well, then I will hand it over to Julie Andrews of Wakely Consulting.
Good morning, everybody. So at this time, the four key components that we use as references or regulatory boundaries for the standard plan design development are still on a proposed or a preliminary basis. If you go to the next slide, the NBBP, which sets the maximum out of pockets, etc., did have its comment period end on January 8th. So at this time, we're just waiting for CMS to do the finalization. Usually the federal AVC finalization follows closely with that timeline. And then the HSA rules usually occur in May after we've done our analysis. And so, anything presented, just sort of keeping in mind that if the regulations change, things may need to be revisited. So what we know so far on a proposed basis, going to the next slide, is that there is a proposed reduction in the maximum out of pockets for 2025. So the proposed overall MOOP is being proposed to decrease from $9,450 to $9,200. And this also will coincide with additional reductions in the maximum out of pockets for the cost sharing reduction silver plan options. Before we get started, there's also, we want to recognize the Covered Connecticut program on the next slide that started in July 2021. So the impact of the Covered Connecticut program was not incorporated into this analysis. There's no program changes currently defined at this time for 2025. And so just to understand that the Covered Connecticut program does impact the cost sharing for those individuals who are eligible for the program. However, they do not factor into the actuarial value calculation at this time. On the next slide, also wanted to go through the changes to the federal actuarial value calculator for 2025. So normally, over the past couple of years, the plan has been just to trend the calculator forward. But with this year, the data underlying the calculator has been updated to reflect 2021 experience. And then that data is trended for at trend rates that were similar to prior rates, but for the 2025 period, we're seeing a little bit higher trend at 6.4% for medical and 9.9% for pharmacy, sort of reflecting the higher utilization and inflationary trend pressures on costs. Some of the updates that have been made with the calculator is that there is, as a result of the change in the data, the allowed cost for the silver and bronze plans decreased by approximately 4%. And so you'll see that reflected in how the actuarial values are playing out, as well as there's been a significant shift in the dollar mix towards the non-preferred and specialty drug types. One of the challenges that they also had with regards to using the EDGE data is that the information with regards to primary care versus specialty care visits are not readily discernible from the data, and so they actually imputed that information using procedure codes. And so what we see in this data as well is sort of a shift in the mix of primary care versus specialty care visits going forward, which also will have an impact on the actuarial values. But before we get started, on the next slide, I just wanted to go ahead and do a little refresher on the state regulations that must also be followed when defining the cost sharing for the standard plans. So at this time, we're unaware of any active legislation or considerations that may be coming up in the 2025 session that may impact the plan design process, but we will keep our eyes open as we see what may emerge. And so, these regulations apply to the cost sharing regulations for the physical therapy copays and advanced imaging copay maximums. And then on the next slide is just a summary of the regulation with regards to the cost for diabetic drugs, insulin, and medically necessary diabetic devices. And so as we develop any changes in the standard plan designs, this will also need to be taken into consideration. So now let's get into the results on the next slide. So, so these two tables kind of provide a summary of the prior year's actuarial values and then the actuarials for the same 2024 plans by metal and cost sharing reduction variation using the 2025 proposed calculator. Each metal tier is defined by a range of allowable AVs as produced by the Federal AV Calculator tool. And at this time, those ranges are not proposed to change for 2025. So in the first table, the top row defines the metal level, the second row defines that range, and then the next row was the final 2024 actuarial value calculations, and then the final row is the same 2024 plans in the 2025 calculator. And these are actuarial values supplied by the plans. You can see in the second table that the 2025 actuarial values are in red font, which indicates that they are outside the ranges and that changes are necessary to be made to those plan designs. So if we go to the next slide, we can start talking about the plan designs. But before we start, just to remember that the Federal AV tool considers just a limited set of key service categories when they look at the actuarial value. And there are, several additional services that are part of the plan design, but that do not fit into the actuarial value calculator. And so are a consideration when, and so therefore are not a consideration when we're calculating the plan's AVs. The next slide is also some additional considerations as we present the plans on the next few slides. So any of the services unless specified, should be considered as in-network only, and the deductible and maximum out-of-pockets are presented at the individual level, unless and the family limits are 2 times the individual limit if it isn't specified in the slides. And then preventive services are always covered without cost sharing. So as we jump into the first plan on the next slide is the gold plan. So the gold plan as it stands for 2024 would be compliant under the 2025 proposed actual value calculator. You can see that the actuarial value range did drop from 81.8 to 82 was the prior range, down to the 79.6 to 80.5. And part of that is, as mentioned, is the shift in the underlying data encompassing the actuarial value calculator. At this time, we did not go back to the plans to consider any changes to the gold plan, but given the current ranges as proposed, there is a potential to go back with some minor reductions in potential cost sharing.
So I assume that that'll be what you'll work on in the next 2 weeks is some suggested changes that might, if we suggest that we could raise this up to a higher level, then we could actually reduce the deductible or the out-of-pocket or both by a small amount.
Right, and that was one of the things that I was wanting to get feedback as to where we would like to look in that. You think, and is to look at the deductible. Now,
but could we maybe next time also see, I know it's ancient history, but the 2023/24 plan, I just wondered how much did we raise it for 24? What was it back in 23?
Okay.
How far back can we lower it again?
Okay, I can incorporate that information.
Plan, is there anything that, okay, yes, after deductible, yes. I know the lab services, it says are $10 after deductible. I imagine it's impossible, but could we look at what happens if we made that before the deductible?
Yes,
it probably would blow us out of the water, but it's always a hope to make as many things not subject to the deductible as we possibly can.
And Grant, back in, I think it was 2022, I think, when we made labs on several plans not subject to the deductible, I think we looked at it at that point and tried for all of them. And I think the gold, right, Julie, was the only one that we couldn't do. We did it for for the silver and the bronze.
Yeah.
That's correct.
Mm-hmm. Yeah. So we've got a few levers here that you can play with, I'm afraid.
Mm-hmm. Well, what we can do is come up with some scenarios for the next meeting. For this round, we were focusing on bringing the non-compliant plans into a compliant option.
Mm-hmm. Mm-hmm.
So what we can do is then, yes, focus on the gold plan. Is there any other suggestions or comments with regards to the gold plan as shown?
No, that's good.
All right. Well, then what I'll do is go on to the silver plan. The silver plan as it stands does comply with the actuarial value bounds for 2025, but we did create an option where we increase the laboratory services copay from $20 to $25. And this is as part of what is occurring on the 73% cost sharing reduction plan. because the cost sharing needs to be always less than or equal to the 70% plan in the cost sharing reduction. So I think it would be helpful to just jump to that 73% plan to understand what are the drivers there on the next slide. So as you can see, the plan as it stood as a 73% plan did meet the actuarial value range. However, with the reduction in the maximum out of pockets, we needed to make a change to comply with that new maximum out of pocket of $7,350. So we did increase the deductible. And so we increased it all the way up to the level of the 70% plan, but was still not within range. And so that is why we, on the 73%, also increased the lab copay from $20 to the $25. And that brought this plan within range. But because of that increase, then that required us to make the change as well on the 70% plan. Now that does leave the 70% plan with some additional room. However, you know, because of the cascading effect of any cost sharing changes made on the 70% plan would flow down. I think it's much more challenging for this year with the reduction in the maximum out of pockets to make changes to the 70% plan at this time.
Gotcha. Yeah.
All right, so moving on to the 87% plan. This one was outside the range, and so what we did was we had, but this one was unique in that it was below the range. And so what we were able to do was to reduce the deductible from $675 to $475, and then also reduce the maximum out of pocket by $200 to the $2,725. So that's good news. And part of that is, as I mentioned, that the actuarial value changes.
Great.
All right, moving on to the 94% plan. So this was a similar situation in that one of the actuarial values was outside the range and required us to make an adjustment to bring both all plans, AVs within the range. And so we increased the out-of-pocket maximum by $100 to $1,150 for this plan. And that brought all of the plan's actuarial values into compliance. I should also mention that as part of, in addition to the actuarial value testing that the plans did, they also validated that the plans will be compliant with mental health parity testing. So unless there's any other feedback on the silver plans and the cost sharing reduction variations, we can move on to the bronze plans. So the good news with the bronze plans is that the plan are compliant with the actuarial value ranges. However, because of the changes in the AV calculator and the changes in the ranges, there is additional room because we're at a maximum of 62.8%, whereas in prior years, we've always been kind of at the top of the range of the expanded bronze at the 65% actuarial value. So there are different things that we could do to this plan. One thing is to change the preferred brand drugs from being a co-insurance of 50% to copay. We could potentially remove the deductible from the specialist visits, we could, reduce the deductible, or remove the primary care, reduce the primary care copay, or try to eliminate as much of the coinsurance drug copays, and potentially even reduce the generic copay as well. So I don't know if all of those things are roughly changes that would fit, I believe, within the 65% range, but the things that I've mentioned would obviously need to go back to the plans to confirm that testing. And so I guess I turn it back to the group as to, if there is a desire as well to make modifications to the bronze plan similar to the gold plan, and if there's any specific cost sharing levers that you would like to pursue.
Does anybody on the committee have suggestions along this line? Julie, I am quite interested in the idea of turning the drug copays, co-insurances into copays.
Yeah.
And maybe lowering the generic also. I don't know just how much room there is there, but that seems to be something that's really, preferable to so many consumers.
And Grant, that was something we were looking at. Oh, sorry, Ellen, from a, health equity perspective as well, is making prescription meds for people with various conditions, making them more accessible.
Yeah, the other one I would think about would be the primary care copay. Not sure what that would entail, but kind of encouraging.
Yeah, certainly.
Yeah.
Okay. So what I will do is looking at, whether we could reduce the primary care copay. Yeah, the silver plan is at $40, so maybe something looking to see if that would be possible to get the bronze plan down from the $50 to that $40 level range. So I will look at those scenarios for our next meeting.
Great.
All right, and then the last plan is the HSA plan. So this plan is compliant as it stands. There is, some range with regards to being at 64%, which is, just slightly below the 65% upper level. Because it's an HSA plan and everything's subject to the deductible, there could be the possibility of reducing the deductible on this plan, or because of the HSA nature, leaving it as it stands for this year, and that way then potentially heading off some additional increases that may occur in 2026.
Have you looked into changing the co-insurances into co-pays for the drugs on this, or at least for some of them? Maybe the bottom, the generic and preferred brands for the HSA plans as an alternative to lowering the out-of-pocket.
Yeah, I mean, I think we can look at that, and just for everyone to remember that since it is an HSA plan, for most things other than preventative, it has to be subject to the deductible. So it's, funkier, but we could, right, Julie? We could look at also maybe changing co-insurance. I don't know what kind of impact that would make on the calculator with the drugs.
Right. Yeah, we could. As you mentioned, though, they would have to have met the 6,500 deductible by the time they got to the copays. So
that definitely does change the attractiveness of it.
Yeah. I mean, this, the HSA plan is for someone who chooses to go this route and hopefully put the money into the HSA account, and then they're using those pre-tax dollars to pay those expenses, you know, out of the HSA, and hopefully getting the tax benefits and understanding how that all works. You know, the only things that are not subject are the preventative. And if you remember from a few years ago, we had to do a bunch of work with the diabetes, right?
Diabetes.
Yeah, the new state diabetes caps, and working it in with the IRS regs on which are considered preventative. So that is integrated into this plan where it's allowable by the IRS reg. So it does have some of that for diabetics, but you know, hopefully diabetics are not choosing an HSA plan. Not their best option, probably. Yeah, but you know, for some people who, and some, you know, we do have a fair amount of enrollment in this plan, and there may be some people who have had money in HSAs from past jobs, and as you know, you get to keep rolling that money over, and so they may have HSA money that they're looking to use, you know, as well. So this plan is attractive to them in that sense too.
Well, yeah, so it sounds like, just to recap, that there is interest in definitely, you know, making some adjustments to the gold plan as well as the bronze non-HSA plan, and potentially looking at the bronze HSA plan, but, you know, acknowledging that with the structure of the HSA plan, there may be some challenges to really making significant changes to that plan. I didn't hear a lot of concern with the alternative options presented for the silver plan and the cost sharing reduction plans. So would I be correct in surmising that those options are acceptable at this time, and that no further options should be pursued for the next meeting?
Did we have a small change to the silver 94% plan?
Yes, we had to increase the maximum out of pocket slightly
Yeah,
to
okay.
1150, or
Yeah,
increased it by
that's
$100.
minor, but that's fine. That seems to be a easy fix for as far as I can see. Yeah.
Yeah.
Okay.
I think the changes proposed there are all minor and make sense to the extent necessary.
Right. Okay. But the gold and the bronze non-HSA are the two to sort of have a lot of alternatives that we need to look at.
Yeah.
This bronze HSA, except lowering the out of pocket might, yeah, I don't know how much you could lower it, but that might be really the only viable change if we make one.
Okay.
Okay.
Yep, so our next scheduled meeting is February 5th of 2024. And following this slide is reference materials just for anybody who might be new to the committee. There's much information in the reference area where it identifies what the plan designs were for the prior year, as well as some information that may have been asked in previous plan years.
Thank you.
We don't have the adjournment slide.
Oh, you don't have an adjournment sign? I was just waiting for it to show up. So thank you very much for the meeting. Thanks, Julie, for all this great information. Seems like we're making small changes to the plan design this year, which is it's good, and in a downward way. I mean, in making them more attractive. So many years they've been going up, sadly. So with no further business, could I have a motion for adjournment?
So moved.
Thank you, Nate. Seconded?
Seconded.
Thank you, Ellen. So could we have a vote on the adjournment?
Graham Ritter,
Yes.
Sean King,
Yes.
Mark Schaefer, Matthew Brockman,
Yes.
Tun Goen,
Yes.
Brendan Riff, Alan Skinner,
Yes.
and Manisha Tutani. Thank you.
Okay, we are adjourned. Thank you all very
Thank
much.
you.
See you on February 5th.
Thank you.
Thanks, everyone.
Bye now.
Bye.